Welcome everyone to today's Global Grand Rounds. My name is Aisha Siad and I will be your host for today. Before we start, I'd like to go over a few things. So this presentation is going to be recorded and uploaded to our YouTube channel. On Zoom, you may turn on a feature called closed captioning during the presentation if you want subtitles. Please also create a Figure One account if you haven't already, if you want to gain CME credits. And I've provided all relevant links in the chat. I will go ahead and hand it over to Dr. Pecchia today to present our speaker.
Thank you, Aisha, and welcome everyone to this version of Global Offsite Care's Global Grand Rounds. I'm Dr. Gregory Pecchia, Medical Director of Global Offsite Care, and of these monthly rounds that started some years ago, I think pushing a decade ago, at the time of the inception of Global Offsite Care, which many of you is dedicated to providing telehealth and telemedicine to access for people around the world in predominantly underserved areas. With that, I am excited and honored to welcome today our guest speaker, Dr. Janice Manjuk, who will be speaking on diagnosing and treating sepsis in a low-resource environment. Dr. Manjuk completed her medical training at the University of Florida, followed by a residency at Kaiser Foundation Hospital in San Francisco and a fellowship in critical care medicine at St. Vincent's Medical Center in New York City. She's been practicing critical care medicine for 30 years and holds an additional certification in neurocritical care. She's the immediate past president and a board of directors member of the Northern California chapter of the Society of Critical Care Medicine, and as well as a national course consultant for the fundamentals of critical care medicine. Her experience includes medical work and critical care teaching here in California, as well as West Africa, Serbia, the Philippines, and most recently, just a few weeks ago in Nepal, in conjunction with Offsite Care, with whom she has worked for years as a staff physician and internist intensivist. With that, I'm honored and pleased to present Dr. Janice Manjuk. Dr. Manjuk, the floor is yours.
Oh, thank you very much. And I'm also honored and pleased to be able to join you today, too. I know there are a number of people who are probably joining this call who have quite a bit of experience in resource-limited areas. And so I'm really anxious to hear your input and questions and thoughts that you can add as well. Without further ado, I'll move on. Since I am getting older now and been working in critical care for a long time, I have had the opportunity to see and teach about sepsis ever since my residency, and that was the area of research for my fellowship. And I saw the Surviving Sepsis program come to pass and be developed here in the United States and all of its various iterations. But I think, as with many things, I've learned that what is recommended with what's presented as a global approach to treating and identifying sepsis really doesn't translate that depending on the setting that you're in. So I've taken interest more recently in looking into various guidelines that are helpful in treating and identifying sepsis in a resource-limited countries. Just to get everybody up to speed, so sepsis is a life-threatening condition that arises when the body's response to infection causes injury to its own tissues and organs. So in my mind, it's like a dysfunctional allergic reaction, although it's not the same mediators that cause the sepsis. And it's the common pathway to death for many infections worldwide. So in the United States, it's common. And every year, about 1.7 million patients get sepsis, and about 20% of them die from it, despite all of our technology and all of our guidelines. Worldwide, it's even a larger problem. So you can see the statistics here, 11 million deaths per year. 1 in 5 deaths worldwide are associated with sepsis. 85% of those are in what are called low or middle income countries, the abbreviation LMIC. And 2 out of every 5 cases are in children under the age of 5. This is a table of incidence, and you can see the darker colors, as you might expect. Sub-Saharan Africa, the Indian subcontinent, and Southeast Asia are common, and then also have a high prevalence of sepsis. And some also over here in South America and Central America. I would say that all of these statistics that we have for incidence of sepsis really should be taken in and evaluated in conjunction with one of the limitations we have worldwide, which is good statistics. And I think that's a challenge for the World Health Organization and many other international bodies, is that we have an idea of sepsis, but there's not a robust way to track cases and even track deaths necessarily. That is something that is being looked at as global initiatives to treat sepsis are rolling out. I think we all have an idea what sepsis is, but I think it's really worthwhile to take a few minutes to talk about this definition of what's a low resource setting, or a low resource setting, or a limited resource setting in healthcare. This is a nice drawing, I think, that sort of indicates and highlights all the different ways that some place can come to be a limited resource setting. So sometimes it's financial shortages, either from a governmental standpoint or a local standpoint, which affects everything, including the basic level of health all the way down the line. You can be resource limited because there's a paucity of knowledge, both basic public health knowledge, personal health knowledge, and knowledge amongst practitioners. You can have certainly an underdeveloped infrastructure where you don't have healthcare settings or hospitals that can really support what needs to happen sometimes. You may also even have problems with electricity, water, as I think everybody knows. There may be some social structures in a community or a country or religious constructs that keep people from seeking. I've had some experience with what the traditional healing practices may be in a country that affect people's access to what you think should be care for sepsis. The health infrastructure is there. There's no really good infrastructure in resource limited countries to fund research, really, epidemiologic research or treatment research comparisons. I think when a lot of us here in the United States and Europe think about resource limited countries, we think that's not us, but it certainly is. So you can see here the healthcare. This is just for primary care. The darker purple and the more intense green graphs are where, even in the United States, there's a shortage of primary care workers. And then during COVID, you can see, and I think everybody remembers COVID, there was a shortage of intensivists all across the world, but certainly in the United States, with Maryland, interestingly enough, being spared. I guess that's the NIH or something. They had 83 extra intensivists for their population, even during COVID, sufficient. And the rest of the United States was limited in one way or another. We became resource limited for personnel during that time. And I think all of us working in the United States now know that the 2 big centers for creating IV fluids in the United States were wiped out by hurricanes. Now we've become resource limited with respect to IV fluids, and a lot of practitioners in the United States are having to learn what to do when they can't give unlimited amount of fluids of any type that they want. They've even had to cancel surgeries. So examples of resource limited settings, just so we're clear about this, come in all different sizes and shapes, and they also can be transient, and they can develop because of all kinds of reasons. So if you have a supply chain issue with IV fluids or medication, you're resource limited for treating people in the hospital, and especially people with sepsis. There's plenty of rural or inner city hospitals and clinics that don't have adequately trained personnel, as we saw before, shortages of intensivists. Plenty of hospitals worldwide, but certainly right here in the United States, don't have adequate diagnostic testing resources. So even simple things like point of care lactic acids or getting lactic acids, you sometimes can't get them at hospitals. There's limitations to imaging studies. So I think we all remember COVID, all of us who worked during COVID, that you could have this wonderful hospital that had plenty of everything, but then all of a sudden you didn't have enough beds, you didn't have enough personnel, and you didn't have enough medications of various types. And then if there's natural disasters, so this is just a shot of the floods that happened the day before we arrived in Kathmandu last month to teach this course, or in September. And that can make things resource limited. For instance, if this were a clinic, all of a sudden they can't get basic supplies there. So personnel shortages and all the things that we've talked about. Now, I do want to just point out for a minute here that there's resource limited medical settings that are an everyday occurrence, and that's how things are every day, and they slowly improve. And a lot of the things that the World Health Organization recommends for treating sepsis are really geared towards those. That's different from what's really described as an austere medical setting, where you have extreme resource limitations. So that's like war arenas, mass casualty events. Humanitarian missions may have limited resources, and natural disasters also. This is just a picture of a hospital in Gaza, where this is probably the most austere setting probably on the planet right now for trying to deliver medical care to a large population that formerly had fairly well functioning hospitals and now has really austere limitations. For instance, 90% of the water in Gaza is not fit for human consumption. There's been a lot of death of healthcare workers. Most of the hospitals and primary care centers are barely functioning, if not functioning at all. That's something that is really difficult to put in the pipeline for study and things. And I'll point out later a couple of references for getting training and experience and working in an austere environment. Okay, so our real goal here, our real challenge is to try to take some of the mortality benefits that all these years of developing guidelines in hospitals like this and see what can be translated to improve mortality and to really be working in a place like a regional hospital. This one is in West Africa, a place I worked before in Gambia. And this is a public health clinic in Kathmandu. So the idea is, what do we know? What do we really know about treating sepsis here, and what can we really do? In the British Medical Journal, they published a study just 2 years ago on sepsis mortality worldwide. And you can see, since 1985 all the way to 2020, we've had a decrease in both male and female mortality. But when you read the article, the vast majority of the data came from countries that were industrialized or in Europe and who had the resources to participate in a World Health Organization database. We really at this point don't know what's happening with the mortality rate in a country, for instance, for all types of sepsis. And that's important to know if we're going to try to see if our interventions work in treating sepsis. I decided to do here for much of this talk is compare and contrast what the Surviving Sepsis Guidelines for the Society of Critical Care Medicine, which is a cooperative guideline that's with the European Society of Intensive Care Medicine and CHEST and several other organizations, and to see what they recommend and what we do and what can be done in resource-limited countries and what we know about the effectiveness of it. One of the first important things is a lot of emphasis in guidelines and training and recognition of sepsis. Okay. In a unlimited resource setting, which I'm going to take as your most well-staffed hospital and clinical setting in the United States, you have clinical screening tools, which are physical exam tools and laboratory tools. And there are even now AI-based screening tools in an electronic medical record and widespread availability of following lactic acids. In a resource-limited setting, obviously, having AI-based screening tools in an EMR is not that common. Being able to get lactic acids is variable. And so we're left with things like screening tools, which are looking at physical exam findings. And the truth of the matter is that these are pretty good clinical screening tools, and some variation of them, which I'll show you shortly, is endorsed by the World Health Organization. But they really haven't been validated well in a lot of pediatric patients, and they haven't been validated well in infections which are not common in the United States or Europe, what are common in resource-limited settings. The Society of Critical Care Medicine sort of defines sepsis as a suspicion of infection with these abnormal vital signs: tachypnea, a systolic blood pressure less than 100, and encephalopathy. And the people who do this screening, both in the United States and in resource-limited countries, are physicians and non-physicians. It's not as simple as when I know it, I see it. It is something that people need to be trained on, trained to recognize. And I know This is very common because when I first started my career, people were very bad at recognizing sepsis. They missed a lot of people. There was a higher mortality. And in fact, there was no emphasis on, look, when I started my training, there was emphasis on treating heart attacks and strokes and trauma very rapidly, but people were very lackadaisical and not really speedy about identifying and treating sepsis. Okay, so these are the clinical exam things that we have here, and we have in resource limited countries. So there's the body temperature, okay, and you can use a thermometer, or you can use things that are subjective, but it requires an assessment tool. So usually a thermometer, and your ability to use this depends on the ambient temperature. I haven't done much of this except with my own child, which is put the back of my hand on them, but it's low cost. It's observer dependent, and it can give you an early warning signs. Definitely in the hospital when I examine patients, sometimes they haven't had a temperature recorded, but you find out in fact they do because they feel warm. Not very high tech, but can be helpful. Skin findings, pallor, cyanosis, skin modeling may be difficult to evaluate in people who have more pigmented skin. And then cap refill time, which I think for many years, a lot of us in critical care, and especially in the United States, we just didn't pay much mind to it because it seemed very low tech. But as you'll see as I go through this, it's really not that low tech. And I'm sure there's people on the call who probably do use this. In the United States, we figure it needs to be high tech to be worthwhile. We check lactic acids. As you can see, these are more expensive. We check venous blood gases from various central lines. We check the difference between the venous and arterial blood gas. And then we actually go on to use things like Doppler, flow assessment Dopplers, infrared spectroscopy, and video microscopy, which actually puts probes in various vascular beds. Those are really expensive, even not widely available in the United States, and certainly not in resource-limited countries. So the World Health Organization, I'm sure there are several people on the call know about this, came up with a set of triage tools. And this is currently what's on their website and downloadable from their website. And so this is a combined screening and triage tool. So you get people identified and moved into a proper area. So I took the one that was for patients over the age of 12. There's other ones that are for children. So there's emphasis on looking for what are called the RED criteria. So these are people at a high risk of death and a high risk of immediate death. And so it's really an A, B, C, D type of thing: airway, breathing, circulation, disability, as with many other screening things like in trauma and in resuscitating sepsis. They look at these vital signs. For disability, they look at altered mentation, active convulsions, whether there's a headache. They throw in everybody here, this isn't just for sepsis, this is for trauma, snake bites, intra-abdominal sepsis. And then there's special concerns and caveats for pregnant women, since maternal death from bleeding and sepsis is pretty high. So we'll talk about this resuscitation area they get moved to. The yellow criterion, people are still pretty sick, but they may not have any of these more severe signs. And then finally, as a check, if you don't have anything worrisome there, but you have these vital sign abnormalities, you actually get reassessed to see if you need to be triaged into an area for rapid resuscitation. And the ABPU is, I think, alert, responds to verbal commands, responds to pain, and is unresponsive completely. And then you use that to triage the patients to a different area. So with children, the World Health Organization does put special emphasis on this. So if a child, and they describe a child, I think they describe it as less than 8 or less than 6 or so. Cold extremities, prolonged cap refill, weak fast pulse, they would get triaged to rapid resuscitation. I don't have the chat box open, but raise your hand if you don't mind, or do the chat response if you use cap refill as part of your daily treatment of patients. Okay, so this can be done in adults and it can be done in infants, and really just is compressing the distal finger. I suppose you can do it on the toe, but it's mostly the finger, and then waiting to see how long it goes back to normal perfusion, i.e. normal color. Now, of course, it depends. You need to have somebody who has what looks like normal perfusion at the beginning to actually do these time criteria. But even if you just have someone who has pallor, you can compress the finger and do this. So upper limits of cap refill time. So for children and adult men, so that's like over the age of 2, I think they have that, 2 seconds. Adult women, 3 seconds. If you're older, 4.5 seconds. These are very coarse things. These are coarse filters for the cap refill. And if you're in a cold environment, then the upper limit may be even higher. Now, for an infant, anything that is less than 1.5 is maybe normal, may represent a very mild degree of hypovolemia. And as you go higher, you can, in a ballpark, gauge it towards the degree of deficit they have based on kilograms. Okay. You can also do it with a slide. That just gives you more effective compression. So you hold it for 10 seconds. It's like a glass slide if you have it. And then you release it. Okay. And you count the seconds till the skin recovers normal perfusion, normal color. So it's used as a screening tool. And it's also used as a monitoring tool as you resuscitate, which I'll talk about in just a minute. It is found in studies to be a predictor of organ dysfunction, to have trending for clinical outcomes in adults and pediatric patients. And it can give you an idea what the intravascular volume status is. So pitfalls, obviously, if you're more pigmentation, it's going to be difficult. Hypothermia, if you have peripheral vascular disease, and depending on the lighting in the room. But it's shown some promise. And these are just some other guidelines for children. So the cap refill won't necessarily tell you if the patient's dehydrated and septic, but it can be used for both these things. So they're just giving you some ideas about kids. If a kid's somewhat dehydrated, this is what their exam will be like. And if it's severely dehydrated, there'll be lethargy and whatnot. And this is a more fancy pediatric sepsis score, which is used as a screen. Really, this kind of, to use the whole score, it really requires that you're getting blood gases, have the ability to go on vasoactive medications and check a lactic acid. But it's pretty good. It's pretty reproducible. And it's pretty good as a screening thing to see whether your pediatric patient has sepsis or septic shock. Okay. So once we've identified that they are, let's just stick to sepsis. Once we identify that our septic patient needs to be resuscitated in the United States, resuscitation starts right away and it's tracked. And if you aren't able to manage to get it taken care of in a timely fashion, you get feedback from various quality people and quality measures. But the rule now is like 30 milligrams per kilogram in the first hour, unless there's a concern about heart failure. And we try to use dynamic measurements. This is what SCCM recommends, and not just the physical exam. So some measurement of the vena cava size, some measurement of stroke volume variation. We follow lactic acid, and you may or may not follow capillary refill. In a resource limited setting, there is a real benefit, it is thought, although not proven yet, to have a dedicated resuscitation area. And because IV fluids are a limited resource, it's not everyone is going to get this just right off the shelf, 30 milligrams per kilogram. It's recommended that you use your IV fluid judiciously and try to assess whether there's hypoperfusion by these things: cap refill, urine output, mental status, blood pressure, and heart rate. So if you go to the World Health Organization site, they have this, and they talk about what a resuscitation area should look like. And it's really similar to what people have in a trauma bay or those 2 rooms at the front of the emergency room in the United States that have all the resuscitation equipment. But this is what they recommend for World Health Organization to make it easy for people. So the rationale is that if you really recognize the people and start resuscitating earlier, you'll save lives. And hard to study, but probably true. So the dedicated resuscitation area is what they recommend. Okay. It's someplace where you're set up ahead of time and you have proper staff to take people from the ambulance to the hospital. The resuscitation area, it can be very simple. You can build it right where your current resources are. So you can rearrange a clinic area for this. You can rearrange sort of an incoming area in your hospital for this. It's centrally located near the ambulances and patient entrances. Is easily visible. The patients will be easily visible as they come in the door by everybody's work area. And it's close to radiology, the ICU, and the operating room if you have those. So they spend quite a lot of time on the World Health Organization training material talking about setting up these resuscitation areas. The equipment and supplies, you have a crash cart, life support equipment, and it should be there at all times, 24/7, ready to go. And then forms and everything that people need to keep track of data and chart vital signs so they don't have to leave the room to go get those. That makes pretty good sense. And then the staff, they're clearly identified, they're trained, and they come immediately when the patient comes through the resuscitation areas. Those things, just like basic life support and cardiac arrest, saves lives. It saves as many lives as advanced cardiac life support. Those basic initial recognition and resuscitation things really help. Okay, so once you have the patient there, what are we going to do with them? We're going to give them resuscitation with crystalloids. This is what SCCM recommends, crystalloids, not colloids. However, if the patient is not responding with an increased blood pressure, for instance, then you might give albumin after crystalloids. If you determine that enough fluids have been given, which we'll talk about in a minute, you give norepinephrine as a first-line agent and vasopressin as a second-line agent, and most times these patients are going to have an invasive arterial line so that we can titrate our therapy to a mean arterial pressure. In resource-limited settings, and I've been in some that were super resource-limited and some that were not so super resource-limited, so there's a wide variety of what's available. So there may be only one vasopressor in the hospital, epinephrine or epinephrine. Since capillary refill time is available at the bedside, that can be used. Urine output can be used, and what happens with the temperature and the modeling. Okay, so there aren't a lot of studies looking at all of these things, but this is one. So I don't know if you all remember this. This was probably about 4 or 5 years ago. It was in JAMA, and it's a Andromeda shock trial is what it's called. So it's looked at really resuscitating patients who were identified to have septic shock with following whether you got them adequately resuscitated by just following peripheral perfusion, a cap refill, or lactic acid. So it was 28 ICUs in 5 countries in South America. So, they had to have certain abilities. They had to have the abilities to have IV fluids. They had to have the ability to do a lactic acid in case that was where their hospital was stratified to. So the outcome was all-cause mortality at 28 days. And you can look, the study there was no statistically significant difference between the lactic acid and the cap refill group. But it's encouraging because the cap refill group was as good as the lactic acid group. It just depends on how you look at the message. I think this was supportive and a pretty reasonably good study. This was supportive of following your index of resuscitation with capillary refill. You could use lactic acid, you could use capillary refill, and it looks like the outcome was similar in these two groups. Because nothing in the United States, especially here in like California, Silicon Valley, gets past the product development people because they can make some of these devices and charge a lot of money where you could just squeeze it on a slide of your finger. So they have in the United States these fancy ways to actually quantify and measure cap refill. And I don't really know how much these cost, but a study like the Shock Andromeda one really made enthusiasm for these devices that mechanize checking cap refill. Okay. I do want to take a minute to talk about why measuring cap refill is so important. And that is because we've learned now that under resuscitating we know is not good, but over resuscitating is probably equally bad. So at some point you have to decide, have I resuscitated enough with IV fluids and should I move to a vasopressor or, a blood transfusion depending on their hemoglobin. So if you under resuscitate, you can have problems with oxygen transport. If you hemodilute, you can have problems with oxygen transport. If you get too much tissue edema, you could have problems with organ function as well. I think we've all probably seen this. Somebody who got like massive resuscitation in some kind of setting and they have pulmonary edema, they may have cerebral edema. You can have conduction disturbance with myocardial wall edema. You can get hepatic congestion. You can get abdominal compartment syndrome. You can get wounds that don't heal. You can get wounds that leak. They dehyst. There's so much fluid in there that you have colonic ischemia. And also it can affect the kidneys. We really do want to not over-resuscitate for those clinical reasons, but also because there's IV fluid shortages. And right now, it's a new thing for doctors in the United States there because of these IV fluid shortages. They're having to really watch how much IV fluids they're using, and we're now all being questioned and asked to justify whether we're giving a lot of IV fluids. In the United States, there's various ways to, and in European countries, there's various ways to gauge your fluid resuscitation. So this is a new one that just came out. It's pretty easy to come on. It doesn't require any technology. It sticks to the skin that measures carotid stroke volume variation with calculation, but it requires this big expensive machine here. Okay. So it's not feasible for a lot of other countries. What is feasible is something simple like a passive leg raise. So this is a situation where you're trying to decide, has my patient gotten enough fluid or not? If I give them more, are they going to respond? So this is a dynamic measurement that you can do. And there's obviously, as with any of these things, there's caveats. Like if they have an intra-abdominal process or they have right-sided heart failure and various other things, this won't be valid. But for many patients, you can use this. So what you do is you check their blood pressure and then you lay them down and raise their legs up for 1 to 5 minutes. And this is like a temporary 300-ish or so for most not incredibly large people or small people, mostly a 300 cc reversible fluid balance. And if the pulse pressure, systolic minus diastolic, changes by more than 10%, it's a pretty good indication that the patient may be fluid responsive. So you could push along with more fluids before you start pressors. The other thing is point of care ultrasounds. I was telling some people just recently about this course we did in Kathmandu, and they did not they worked in the hospital, so they didn't work in the ICU or ER, so they didn't know anything about this. But this is really an exportable technology, okay? Assuming you can get somebody to donate the probes, or you somehow can get one for your hospital or one for your clinic, and it can hook up to a smartphone or an iPad, and you can actually get very reasonable images of the heart and the inferior vena cava. So the easiest one to do is just an IVC examination. So you look at the IVC, which is measured in a subcostal view, and then when they inspire, you see how much it collapses. So you want to measure the baseline diameter of the IVC, then how much collapse there is when they take a deep breath, and it'll give you an idea of what the patient's right atrial pressure may be, and it'll let you know whether you should get fluid or not. For most of us, this is probably a little bit better than a CVP, but it's not perfect. There's caveats, but it's an easy thing you can do at the bedside to gauge fluid resuscitation. They don't talk a lot about it in the guidelines because I think it is hard to get these devices. But the good thing about them is that unlike a conventional ultrasound machine, they're sturdy and they're covered with a pretty sturdy cover. So if they get dropped, they still work. They, have a pretty long shelf life. There's no pieces and parts to, other than a cable, if you have a cable one, there's no pieces and parts to try to fix. So it's a good product. And some of the companies have really started exporting these to resource limited countries in conjunction with teaching. It's a pretty good tool. All right. So we've given the fluid, we've given the pressors, we've determined we have enough pressors on board, and in conjunction with that, we're giving an antibiotics. It's reasonably simple in the United States. You're supposed to give the antibiotics within an hour. You're supposed to monitor and hold the antibiotics. If there's not clearly an infection, you can check a procalcitonin to help you decide how long to keep the antibiotics on. You have stuff available for multi-drug resistant organisms and MRSA. You have fancy ways to infuse the antibiotics in a prolonged fashion, which may make them more effective. You usually have somebody around who can puncture an abscess or operate. And the hospitals really keep close eye and the infection control department about de-escalating antibiotics. In a resource-limited country, it depends on how resource-limited you are. So there's still a goal to give antibiotics in the first hour, but the challenges are multi-drug resistance may be higher in certain countries, either because there's a lot of empiric use because you can't get cultures and sensitivities, or there's over-the-counter usage, or there's overuse because of the local practice, or maybe how in extremis a patient is. Many of us who get a patient into our setting who is really like in extremis, maybe far down the line for having, their infection starting, a lot of times we'll give very aggressive antibiotics. So if it's taken someone a long time to get into the hospital from wherever they are, they're going to look bad when they get there. So the natural inclination is to give a lot of antibiotics. We also have there also is limited access to alternative antibiotics, and antimicrobial stewardship is not that common, in a lot of countries. So the World Health Organization is trying to tackle that with guidance that's available online. And they have this thing called the Aware Antibiotic Book. So the Aware Antibiotic Book is this. It's an evidence-based guidance. It's not based on country. They based it on disease process, like whether it's a urinary tract infection or pneumonia, whether it's community acquired or hospital acquired. And obviously it's heavy towards antimicrobials and antifungals and somewhat antivirals, but there's not much information in there. There's some, unlike protozoal and other parasitic infections. But anyway, they list the common 30 of the most common clinical infections in adults and children. And the AWARE is this. They help you come up with a formulary at your local settings. The green one is the access antibiotics. So they have narrow spectrum of activity, the lower cost. They're less likely to get resistance because of the type of antibiotic it is. And these are really the first or second line choice. The watch antibiotics are broader spectrum ones, higher cost. They're recommended for your super sick patients, or where you think there may be resistance because you figure that out either clinically or by microbiologic data. And then the reserve antibiotics is the last choice for multi-drug resistant infections. So they also have a fourth group, which is not recommended either based on lack of efficacy or toxicity or resistance. Pretty helpful. I'm sure it should be an online book because I'm sure data changes all the time. And unfortunately, the pitfall is that it's not really tailored to an individual country, which I think makes it challenging to use it. But it is a good place to start if you want to get your formulary together. Okay, the other thing I think is important to talk about is mechanical ventilation. This may be the place where there's the biggest divide between unlimited resource countries and resource limited countries. So the Surviving Sepsis Guideline realizes that a lot of these patients end up needing a ventilatory support or oxygen because they develop ARDS. So there's a recommendation that we try high flow nasal cannula before we put someone on non-invasive ventilation or mechanical ventilation. And that really has to do with, we had a lot of experience with that in COVID. And we also realized that we could avoid intubation by using this and that it was pretty efficacious, primarily if it was a oxygen need that someone needed. If they end up on a mechanical ventilator, you need to use a low tidal volume, not a large tidal volume, which is like 6 cc's per kilo predicted body weight. You need to use high PEEP if it's ARDS. If it's severe ARDS, they recommend you prone a patient. And then, use neuromuscular blockers and then default to VV ECMO. Okay, so I'm not guessing there's a lot of VV ECMO in resource limited countries. So I can tell you from doing medical mission work in the Philippines. I think the 6 different places I went all over the country, I think people had oximetry because that's easily available. Oxygen was a limited resource of some of them. Ventilators were often broken when we got there. And, luckily the missions I went on brought 2 biomedical engineers so they could fix the ventilators. Proning as possible and ECMO was just a no-go. Sorry. So, like in the United States, this is high-flow nasal cannula for those of you who may not have seen it. This is a non-invasive ventilator, a mask where it works similar to a mechanical ventilator, and this is obviously intubation. I think that I never saw this, and I never saw this in many of the places that I volunteered at. What I did is I saw this as a ventilator. This is still seen in the United States, and this is a Bird ventilator. I think that's the company that makes it, and sometimes use it as a transport ventilator. And this is the ventilator that has all of the things that are required by the Food and Drug Administration to have in the United States. You have to be able to have measurements of pressure. You have to have a set of alarms. You have to have some almost all of them have graphical things where you measure these airway pressures that you need to use to give your patient the safest ventilation. This one does not. Okay, it has a gauge that kind of goes back and forth, and it's difficult to use. Guidelines that I didn't list them all, but guidelines that talk about keeping the airway pressures here or there and titrating the PEEP, and that's really just not possible with a ventilator such as that. That's something that is not going to really be feasible to enact in a optimal mechanical ventilation strategy if you're resource limited. The other thing that I have learned, and I think more physicians in the developed world, the resource unlimited world, are finding out is that oxygen availability is a big deal. So we're all used to this unlimited oxygen that comes from like magic out of the wall somehow at the hospitals. And it's always there. It never runs out. And it's like wonderful. And it can be titrated and it can be hooked up to anything you want. In a lot of resource limited countries, it's difficult to get oxygen. You have to either have tanks that have to be delivered and they're expensive and have to be refilled. You can get an oxygen generator. This thing is like big. It's 6 feet tall, 8 feet tall. These will give you oxygen forever, but they are super expensive. And as you can see, a lot of pieces to break. And then there's an oxygen concentrator, which has a lot of things that can break as well, but it can give you an unlimited supply of oxygen. So this is a big deal. And I found one study that just talked about mechanical ventilator availability and availability of other things in, let me see, low and medium income settings, and this was during COVID. Most places who took care of COVID patients did at least have electrical supply or a battery or a generator, but 20% or more had daily outages. As far as oxygen, roughly I think about 70% of places had oxygen. Some of it was compressed air and some of it was an oxygen concentrator or a large tank. And these were all subject to the need outstrip the availability. There were people who didn't make it through COVID because there was no way to deliver oxygen at all, much less through a ventilator. Pulse oximetry is pretty available because it's small and inexpensive. End-tidal CO2 monitoring is not that available. And as I said, ventilators with pressure monitors and graphs are variable availability. Okay. Okay, so just to round it up, the World Health Organization, Society of Critical Care Medicine address these things. So these are other therapies, okay? So giving corticosteroids, pressor dependence is prolonged. Many resource-limited countries have steroids. They may not have the absolute formulation that was required, but if it has enough glucocorticoid and potential, you could use it. Restricted blood transfusion strategy. They just don't want you to give people too much blood, more than what they really need, which I think is probably for sure happening in resource limited places. They recommend low molecular weight heparin. I don't know how available that is, and I don't know the cost. The cost differential for that depends on the country. They recommend that people who are hemodynamically stable get continuous renal replacement therapy, it can be done without a machine, but it is hard to do and hardly ever done without a machine. That's how it was done when this technology first came to pass. They want your blood sugar to be less than 80, greater than 140, and provide some sort of intraoral nutrition in the first 72 hours. These are interventions that have been shown in a lot of studies to save lives, but they may not necessarily be available. And then the last category of things that they talk about in the surviving sepsis guidelines is essentially geared towards educating the family, counseling the family, and helping the family or patient to accept that they may not survive. And also taking people who do survive and putting them in a rehabilitation facility so they can get cognitive and physical function back. That last one is poorly available even in the United States. Palliative care is variable. So I have a few friends who did palliative care internationally, and there is a worldwide sort of deficit of palliative care in these kind of things. We probably should just mention is prevention of sepsis is super important. In the United States, it's really hospital oriented for prevention of sepsis, making sure we have good hand hygiene, making sure there's antimicrobial stewardship, getting rid of any invasive mechanical devices as soon as possible, isolating patients, and having plenty of PPE, which none of us had at the beginning of COVID, but now we have plenty. And many of the resource limited recommendations are the same, but they also address sort of the public health sanitation issues before you get to the hospital. It is something to not forget because you can prevent sepsis, and you can prevent sepsis really with simple things like clean water, washing hands. All right. So I'll just give you a little run through about some of the clinical tools that are available. So the World Health Organization realizes that their data is no good and limited in what's happening for sepsis worldwide. So they have a clinical registry. I do think it is internet-based, computer-based, but that's something that they're trying to do so that they can maybe get data like that first one we saw at the beginning that talked about the change in sepsis mortality and drill down better on sepsis mortalities in various countries. So they have ways to train people virtually for that. A whole bunch of really good resource online references that are a little bit more specific. So they have sepsis, antimicrobial guidelines, which I showed you. Then they have some for dealing with viral hemorrhagic fever, Ebola, dengue fever, and even MERS. So they give you clinical management tips, which for experienced, physicians and staff, It's good to take a look at it. For people who are either new to taking care of patients like this or newly in a position of running a unit or an ICU or an ER, these are really helpful guidelines and checklists. So for instance, one of these is just making sure that people have a good definition of what severe malaria is, so they know that this is a patient that if they think that they'll be able to survive this, they'll put a lot of resources into it. I'm sure people who treat malaria regularly are familiar with these manifestations. Okay, so their goals are clear. They want to reduce preventable deaths, especially maternal and neonatal. They want to improve clinical management. They want to support member states, being countries that want to sign up for the program of trying to attack sepsis deaths. They want to integrate the role of treating sepsis with other things like maternal health, promote research, support low resource settings, raise awareness. So this is really teaching the general public about sepsis. And then they do want to collaborate with partners. And by partners, they mean things like Society of Critical Care Medicine and other international bodies that have the same role. So the Society of Critical Care Medicine is the one that I've worked with my whole career. And I would say it took them a little bit of time to understand that what they're recommending at Mass General wasn't going to work in other countries. And so as I taught this FCCS course in other countries, some of it was a little ridiculous because we're talking about lactic acids and procalcitonin, and it was just not appropriate. So now they really have a project and funding to approach treating sepsis in a low resource setting. In conjunction with that, they have a series of these fundamental critical care support courses. And I would say that I've been teaching this one over here, this fundamental critical care support, since the first edition. And not only has the course improved, but it's become more sensitive to resource limited settings. The pediatric one is excellent, and it really helps, I think, people definitely take better care of pediatric patients to help them survive. And then finally, this resource limited one gives guidelines, especially if you have a limited amount of IV fluids or things. And it's really geared a lot towards austere environments. But it's good, and you can do that online as a self-taught course if you're interested. And by the way, if you're they sell these courses online in a tiered fashion, depending on the gross national product, I think, of your country. They charge you various amounts. And then for our course that we did in Kathmandu, we were able to get grants and it was free. And here's our course that we did. Okay. So we were there for 2.5 days teaching and getting ready. So we did teach the point of care ultrasound course, and some of these simple views were very easily gotten by people who had never picked up a probe. And as you can see, this probe is wired into an iPad, but you could easily hook it up to a phone. And some of the people there who were in critical care training, who were anesthesiologists, like this fellow over here, had some experience with ultrasound, but it was super helpful for them. And then they took the fundamental critical care support course, which was generously supported by a number of organizations, including Offsite Care here. And I guess the point of this slide is that thank you very much. And I had a very nice time also in Kathmandu, and happy to have Global Offsite Care funded. Anyway, thanks for listening. And I would love to hear comments or questions from anybody who would like to share something or correct me on something too.
Great. Thank you, Dr. Manchak. I'm logged in from a mobile device, and I was fortunate to be able to stay on the whole time, and that was awesome and super helpful. Quick question from myself and leading for a few others before we close at 9. What would you say would be a bare minimum starter kit for a very low resource environment to at least be able to tide over someone who might present to a small clinic in a remote environment, who can be identified quickly as being septic and needing resuscitation? What would that starter kit look like?
A tackle box. I thought about this a lot when I was looking at all this data, and I didn't make up a list on paper, but I have a list in my mind. So one would be like a paper screening checklist, so you can identify these people right off the bat. I think some thermometer. I think that obviously some crystalloid, some IV fluids, what antibody you get. I have to say ceftriaxone, a couple of times people have donated to me a pallet of ceftriaxone, which could be parsed up and used in various size people, and it's good for a lot of antibacterial infections. Sometimes Tylenol, IV Tylenol is gettable, oral Tylenol is helpful. I think I said a pulse oximeter. And then I guess if you had to have one vasopressor, I would say norepinephrine. If you're lucky, that's a short list of things. There's some other equipment needs, but those are pretty good. Oxygen, it's hard to have oxygen, but having some sort of oxygen that you have, it's just how you use it is going to depend on whether it's a tank or a concentrator.
Great. Thank you. That's super helpful. I think we've got about 5 minutes left. I'll give it up to Aisha to walk through any other questions that might be out there amongst the audience, and then I'll sign off now in advance of that. And thank you again, Dr. Manczyk, so much for being with us today. That was fantastic. You take care.
Okay, thank you. Okay, Aisha, you gonna hook up the people with questions here?
Yeah, Dr. Otto has his hand raised.
Hi, sir.
Hello. Thank you so much, Dr. Manczyk, for that wonderful presentation. Can you hear me loud and clear?
Yeah. Yes.
Yes. Okay. Mine is both a question and a comment. Let me start with a comment before I can ask. I want to add a small contribution to the presentation on the geographical distribution of sepsis. That's slide number 5. If you can go to slide number 5. When you look at it, yes, when you look at it, maybe what I wanted to add on is sepsis is also geographically distributed. So it has something to do with the tropical region. When you look at it carefully, you realize it's more rampant in sub-Saharan Africa, and then the Indians and the South American. These are basically tropical. It's more in the tropics. If you look at it carefully, it's more into the tropics where it's a hot and wet climatic region. And these areas are prone to the microorganisms that tend to flourish better in a wet and warm climatic region. So that's also a factor that I wanted to add on. Then the other thing also I wanted to contribute is for us in Africa, particularly in Uganda here, where resources are purely limited, we depend a lot on CBC, which is more readily available, and the clinical judgment to diagnose septic patients and patients who are tending towards sepsis. So we have not been benefiting from the luxurious investigations like CBC, culture and sensitivity, and other investigations. So we depend purely on temperature monitoring, clinical judgment, CBC, and maybe shooting patients with the broad spectrum antibiotics. So that's what I wanted to, that's the comment, Andrea. Then maybe to the question, does blood culture have a role in the diagnosis of septic patients? Because I didn't see that come up in your presentation. Otherwise, once again, thank you so much for the beautiful and wonderful and informative presentation. I remain Dr. David Otto from Uganda, a resident in orthopedic surgery. Thank you.
Okay, you're welcome. Yeah, blood cultures are listed actually on the bullet points as a recommendation for Society of Critical Care Medicine. But in terms of initial treatment, so it's not a role in initial treatment. You should try to get them, but that's not just like procalcitonin, if you have availability of that, you don't use either of those to decide whether to start to treat someone. So the real role of blood cultures is to put that into the mix, whether you can de-escalate or even stop antimicrobial therapy. So let's say you find an alternative diagnosis, and also to guide resistance. But I have a question coming back at you, and that's, how do you determine antimicrobial resistance in your setting? Is it because lack of clinical response, or do you have a default to send it out someplace, or what? Yeah.
Yes, okay. Yes. Thank you so much. It is actually becoming a concern these days. Antimicrobial resistance is becoming really a great concern, and a lot is now being done because, yes, like I said, we basically do a lot of clinical judgment, but also we shoot patients with the broad spectrum antibiotic, and this in the long term, there was a worry that we might enter into a phase of total antimicrobial resistance, which is now beginning to surface these days. For example, yesterday I did a culture sensitivity on a patient with the chronic osteomyelitis, and surprisingly, literally all antibiotics were resistant apart from the epinephrine. Now, that was already, because it was resistant to ceftriaxone, penicillins, all the levofloxacins were all what? resistance. So it really is a big problem here. As you said, it is a very big problem. We are now facing that. Yeah. Thank you.
Yeah. Yeah, with the places I've gone in the Philippines, not only they couldn't get blood cultures at all, so you're practicing without blood cultures. I did notice that even the doctors on the medical mission who came from the States, they tended to give antibiotics, even antimicrobial prophylaxis. They would give it for a long time, and they would make it very broad. And it was tough to say what kind of alternative they had. Yeah. Other questions or comments? I see a lot of expertise out there.
All right. If anyone has any last questions, please let us know. Otherwise, we are coming towards the end of our time. Okay, I don't see any more questions. If you do have anything, you can let me know and I can relay it to Dr. Manjuk. So let me.
Yeah, I just had to say I was very honored to be able to talk to you all. I'm far from an expert, but I continue to learn more and more about treating this all the time. And so maybe sometime I'd love to hear one of you all talk about your local experience, which I'd love to hear about. So
right.
Thank you very much.
Thank you so much. It was an amazing presentation. If you guys, we have the links in the chat in regards to our website, YouTube channel, Figure One, and my email is there if you have any questions or if you're interested in presenting. Our next presentation should be December 11th. And yeah, as always, thank you guys very much. Have a great day.
Yeah, and I definitely hope some of you all want to present sometime. That would be wonderful and interesting. So thank you.